we're diving straight into high-yield clinical neurology today, specifically targeting neurodegenerative and motor unit pathologies. Look, we are going to navigate some of the absolute densest cognitive branch points you'll face on the wards and the boards. We're filtering out the background noise and zeroing right in on the specific diagnostic algorithms and those devastating cognitive traps that you just absolutely have to master. Here's the roadmap for this explainer. Module 1, Neurodegenerative Dementias. Module 2, Vertigo and Equilibrium. Module 3, Demyelinating and Motor Disorders. And finally, Module 4, Accelerated Pattern Recognition and Traps. Let's hit it.
Module 1, Neurodegenerative Dementias and Workups.
All right, your very first major branch point is the actual chronology of cognitive decline. You've got to rapidly contrast the initial presentations of the big three. First, Alzheimer's disease. It's insidious, right? It presents with this progressive, early short-term memory loss driven by diffuse cortical atrophy that kicks off in the temporal lobes. Now contrast that with vascular dementia. This one is stepwise. You're looking for sudden drops in cognition that perfectly match up with historical cardiovascular events and new focal neurologic deficits. And then we have frontotemporal dementia, or PIC disease. The huge trap here is assuming all dementia starts with memory loss. No way, it absolutely doesn't. FTD hits you with early behavioral changes and profound disinhibition, often while the patient's memory is perfectly intact initially. So once Alzheimer's is confirmed, and you'll often see this supported by an MRI showing diffuse cortical atrophy and ventriculomegaly, we have to DAC management. The cognitive impairment here is directly tied to decreased cholinergic signaling in the cortex. So your definitive strategy mandates cholinesterase inhibitors, like donepezil. By reversibly inhibiting acetylcholinesterase, we're basically pumping up the synaptic acetylcholine. Now, be clear with your patients. This modestly improves functionality and slows down the progression, but it's definitely not a cure.
Okay, let's look at two other massively tested dementias. Normal pressure hydrocephalus, or NPH, serves up that classic wacky, wobbly, and wet triad. We're talking cognitive impairment, a magnetic gait where the patient's feet literally feel glued to the floor, and urinary incontinence. To confirm it, and sometimes even treat it, you go for a high-volume therapeutic lumbar puncture. Next up, dementia with Lewy bodies. The hallmark triad here, fluctuating cognition, these incredibly vivid visual hallucinations, and spontaneous Parkinsonism. And by spontaneous, I mean motor symptoms like tremors or rigidity popping up without any other known cause.
So this brings us to a really high-yield clinical challenge. Consider this vignette for a second. A 72-year-old man presents with a one-year history of cognitive fluctuations and visual hallucinations, which is then followed by arresting tremor onset just 2 months ago. So what's the definitive diagnosis? Are we looking at primary Parkinson's disease, or is it Lewy body dementia?
The absolute crucial differentiator here is the timeline. The answer is Lewy body dementia. You really need to internalize the one-year rule. If the cognitive decline and those neuropsychiatric symptoms, like those vivid hallucinations we talked about, show up before or concurrently within 1 year of the onset of motor symptoms, boom, it's Lewy body. Primary Parkinson's disease, on the other hand, is a totally different timeline. It presents with classic motor symptoms, bradykinesia and rigidity, for years before any cognitive decline even begins to set in. So, let the timeline dictate your diagnostic path.
Module 2, Vertigo and Equilibrium Pathology Branch Points. All right, we're shifting gears, moving from the cortex down to the vestibular system. When a patient walks in with vertigo, your immediate #1 job is to separate a benign peripheral pathology from a life-threatening central brainstem lesion. Peripheral vertigo typically gives you horizontal, fatigable nystagmus and absolutely no focal neurologic deficits. Central vertigo? That's a massive red flag. You'll see vertical, non-fatigable nystagmus and positive focal CNS deficits. We're talking weakness, diplopia, or severe ataxia. If you see those central signs, you immediately trigger neural imaging. No questions asked. Now, the most common peripheral cause is benign paroxysmal positional vertigo, or BPPV. This is quite literally a mechanical plumbing problem, calcium debris or otoliths floating around in the semicircular canals. Patients will describe these brief, intense waves of vertigo triggered just by moving their head, like rolling over in bed. The critical distinction you have to make here is separating your diagnosis from your treatment. We use the Dix-Hallpike maneuver to provoke and actually confirm the diagnosis by watching for that fatigable nystagmus. But to treat it, that's the Epley maneuver. You're physically repositioning those calcium particles right out of the canal. Let's look at another diagnostic branch point. This really highlights how a single symptom can change your entire clinical trajectory. Both vestibular neuritis and labyrinthitis present with acute, severe, continuous vertigo and vomiting, almost always following a viral prodrome.
So how do you tell them apart? It all comes down to hearing. In vestibular neuritis, their hearing is perfectly normal. But in labyrinthitis, the inflammation extends further into the inner ear, resulting in unilateral sensory neural hearing loss. That right there is your definitive differentiator. Okay, let's test this with another clinical scenario. A patient comes in with acute episodic vertigo, lasting roughly 2 hours, right-sided tinnitus, earfulness, and documented sensory neural hearing loss. What is your next best step in management? Are you ordering a brain MRI, or are you starting dietary sodium restriction and diuretics? The correct move here is dietary modification. This is the absolute classic presentation of many years' disease, which is driven by endolymphatic hydrops, basically an excess of fluid pressure in the inner ear. Because episodic vertigo paired with tinnitus and hearing loss firmly 100% localizes to the peripheral vestibular system, ordering a costly MRI is a massive diagnostic error. You don't need it. Instead, you start by restricting sodium and initiating diuretics to bring down that inner ear pressure. Module 3. Demyelinating and motor unit disorders. We are now moving deep into the spinal cord and peripheral nerves. Let's break down MS and ALS. Multiple sclerosis causes neurologic deficits that are disseminated in time and space. Classic presentations look for optic neuritis and internuclear ophthalmoplegia, or INO, which is this highly specific conjugate gaze palsy where the eyes just don't move together properly. You'll confirm MS with a brain MRI showing those periventricular plaques we call Dawson's fingers, or by tapping the CSF and finding unique inflammatory proteins known as oligoclonal bands. Now, sharply contrast this with ALS. ALS ruthlessly destroys both upper and lower motor neurons simultaneously, so you get spasticity right alongside atrophy and muscle twitching. Crucially, though, in ALS, sensory function is completely spared. For management, you're relying on riluzole to decrease glutamate exotoxicity, which modestly prolongs survival.
Next, we've got to contrast two tricky disorders of the neuromuscular junction. First, myasthenia gravis. This is a postsynaptic disorder driven by acetylcholine receptor antibodies. Clinically, you are going to see fluctuating weakness that distinctly worsens with muscle use. And remember, it's heavily linked paraneoplastically to thymomas. On the flip side, we have Lambert-Eaton myasthenic syndrome, or LEMS. This is a presynaptic disorder involving voltage-gated calcium channel antibodies. Unlike MG, LEMS presents with proximal weakness that actually improves with repeated muscle use, and classically, it's linked to small cell lung cancer.
Let's see how this actually presents in a patient. Picture a 57-year-old woman presenting with progressive fatigable ptosis and bulbar weakness, meaning she's having serious trouble swallowing and speaking. A chest X-ray reveals a mediastinal mass. Guys, this is textbook myasthenia gravis. That fatigable ocular and bulbar weakness immediately mandates repetitive nerve stimulation, which is going to show a decremental response. Plus, that mediastinal mass means you absolutely must screen for and surgically remove the underlying thymoma. You have to do that to halt the autoimmune progression. Moving out to the peripheral nerves, let's talk Guillain-Barré syndrome, or GBS. The pattern you're looking for is an acute, ascending, flaccid paralysis with absent reflexes. This typically flares up following a GI infection, famously Campylobacter jejuni. You're going to support this diagnosis with a lumbar puncture revealing albuminocytologic dissociation. That's a mouthful, but it just means high protein with totally normal white blood cell counts in the CSF. The definitive treatment mandate here is either IVIG or plasmapheresis. And here's the kicker. Avoid systemic steroids. They are completely ineffective for this specific nerve pathology and literally only delay the definitive care your patient actually needs.
Module 4. Accelerated Pattern Recognition and Neurological Traps.
All right, for our final phase of this explainer, we're going to actively challenge some cognitive biases with high-stakes clinical errors. Trap number 1. Prescribing donepezil for a patient with early behavioral disinhibition. Listen, if the clinical picture matches frontotemporal dementia, throwing cholinesterase inhibitors at them is a massive error and can actually worsen their behavior. FTD is a tau or TDP43 proteinopathy. It is not an acetylcholine deficit. Trap number 2. Misinterpreting benign, age-related cognitive slowing as pathological dementia. The strict separator here is functionality. Normal aging allows a patient to maintain their independence with daily activities. Pathological dementia, it completely strips that independence away. Let's look at 2 more really dangerous management traps. Trap 1, administering systemic corticosteroids during an acute GBS flare. Like we literally just discussed, steroids have zero proven benefit here and simply delay life-saving therapies like IVIG. don't do it. Chop 2, trying to aggressively manage a myasthenic crisis with medications before securing pulmonary function. If a patient with MG presents in a crisis, your absolute first step, before you even think about acetylcholinesterase inhibitors, is to measure their forced vital capacity, or FVC. Failing to secure the airway first leads directly to unrecognized respiratory failure and potentially death.
I really want to drive home this overarching pathophysiologic principle because it saves lives. Always prioritize your ABCs, specifically airway and forced vital capacity in any ascending or bulbar motor failure. Honestly, whether it's GBS marching up the spinal nerves, ALS destroying motor neurons, or a myasthenic crisis blocking neuromuscular transmission at the junction, the ultimate mechanism of mortality is always diaphragmatic failure. Secure the FVC first, period.
We are going to conclude with a final provocative integration thought. Imagine a 60-year-old presenting with insidious behavioral changes, a new-onset spastic foot drop, and fatigable ptosis. You've got frontal lobe, motor neuron, and neuromuscular junction signs all overlapping at once. So, when multiple distinct systems fail simultaneously, which diagnostic algorithm do you trigger first? How do you prioritize your workup when textbook presentations just blur together in the real world? Keep that complex scenario in mind as you tackle your next block of review questions. Keep synthesizing, keep questioning, and keep learning.